So as I said, my name is Elaine Toomey. I'm a lecturer in physiotherapy in the School of Allied Health in the University of Limerick in Ireland. And I'm going to be speaking to you today about physical activity for older people with non-communicable diseases. And I suppose particularly looking at group and community-based approaches. Okay. So today, just to give you a sense of the types of things I'm hoping to cover. So first, to look a little bit at the prevalence, impact and management of chronic non-communicable diseases, or NCDs, as I'm going to call them for short. Excuse me, there's a fly who's just come into the room out of nowhere. I don't know where that fly came from. So apologies if I do this every now and then. Okay, and then the second thing we're going to look at is understanding the importance of physical activity for older people with NCDs. And then finally, we're going to look specifically at exploring community and group-based approaches, and particularly looking at some physical activity programs that exist already for older people with NCDs, and then thinking a little bit more about the role of the physio in this, and looking at the role of the physio more broadly in promotion of physical activity for general health as well as for clinical populations. Okay. So before I get into that, I just want to introduce myself to you. So I have presented before for UFAPA in the rehab program, but I may not have met some of you before. So this is where I live. So this is on the west coast of Ireland, and this is Galway City. So this is where I live. This is where I work. So I work in the University of Limerick. So this is where I did my bachelor's in physiotherapy and also my master's. So my master's was looking at physiotherapy community-based approaches to physical activity for older people with multiple sclerosis. And this is an hour south of Galway where I live. So this is where I work, is an hour south of there in Limerick City, also on the west coast of the country. And then this is where I did my PhD. So I did my PhD then also looking at community-based approaches to people, to physical activity for people with chronic pain conditions. And I did this in Dublin, which is the capital of the country, obviously, on the east coast of the city. So just to give you a little bit of a sense of my background, where I'm coming from with some of this and where I'm currently based. And I suppose with those research focuses, I would have also had a fairly strong clinical focus with them as well. So I would have worked in private practice during both the master's and the PhD in these areas. Okay, so that's where I come from with it. So after my PhD, then I moved to Galway, where I currently live, and I wanted to kind of look at, I suppose, health promotion and prevention of chronic disease more broadly than just physio. So I worked for 3 years with the Health Behaviour Change Research Group in Galway. And this was just looking at, I suppose, generally outside of physio, what's the preventive focus? And as healthcare professionals, how much of a role do we have to play in preventing chronic NCDs in the first place? And what can we do there? So this is where I'm based currently. So back to the place I started in. So in the University of Limerick. So I'm a lecturer in physiotherapy now, and I've been there in this university for the last year. Okay. So I guess before we can really understand, I suppose, why physical activity for older people with non-communicable diseases is important, I guess we first need to kind of think about what NCDs are and why it's so important that we address them. So chronic conditions are long-term conditions lasting more than 6 months. They're non-communicable and typically involve some functional impairment or disability and are usually incurable. So this is a definition taken from the Irish Department of Children and Health. And I suppose I kind of like this one because it's just neat and kind of tells me a little bit all I need to know for the time being. What we know about NCDs is that they're responsible for almost 70% of deaths, all deaths worldwide, which is a particularly staggering statistic. So I don't know why this keeps kind of jumping ahead of me, so apologies for that. But I might just see if I can stop it doing that. I don't know why. Oh, hang on. I'm going to pause this for a second. So I'm just going to stop sharing for a second. So apologies now for this. Just 2 seconds, apologies. I think it's just using the timings. Okay, so I'm going to reshare again. Okay, so I should be back to you now, and hopefully that won't keep jumping on me. Okay, so looking then at the types of chronic conditions that we're interested in, and I suppose a lot of these that we see as physiotherapists and that we will see in our practice. So there's respiratory diseases, so COPD, so chronic obstructive pulmonary disease, asthma. There's also diabetes. So while we may not treat this particular condition in and of itself, we'll often have patients coming into us, especially in the older population who have this disease. Cardiovascular disease, so heart attacks and stroke. And again, physio has a big role in working with people post-stroke. And then cancer, so different types of cancers are also chronic conditions. And then other chronic pain conditions where, you know, predominantly we have quite a strong role. So things like rheumatoid arthritis, osteoarthritis, chronic back pain, and then neurological conditions like Parkinson's disease or multiple sclerosis. So I guess when we're talking about NCDs and chronic conditions, these are the types of conditions that we're typically talking about. Okay. So in terms of the prevalence of these chronic conditions, we know that about 3 in 5 global deaths are attributed to either cardiovascular disease, cancer, chronic lung diseases, or diabetes. And we also know that approximately 1 in 3 adults globally suffer from multiple chronic conditions. So not just one of these, but a couple of these co-occurring at the same time. So data would be different depending on the country or the area, but it ranges from maybe about 16 to 58% in some UK studies, about 26% in US studies, and then in another study of urban South Asians, it's been about 9.4%. But we know often, and especially as people get older, they're more likely to have more than one chronic condition. So it's always important, I suppose, to have that in your mind as well. Okay, so thinking about internationally then, the burden of these diseases, we can see here that of the top 10 global causes of deaths in 2016, ischemic heart disease was the key one, followed by stroke, COPD, and then Alzheimer's, some forms of cancer, diabetes, and these blue bars being the non-communicable diseases that we're talking about here. So we even just, I suppose, thinking about the context in where we're working and what the whole global picture is, we see that these chronic NCDs are really impactful and play a big role in shaping society and in shaping how things happen. So in Ireland, looking at some of the stats here, and it's probably similar for the Ukraine and for where you're based. I apologize, I don't have the Ukrainian stats, but in terms of Ireland, about 70% of healthcare service utilisation is taken up by chronic NCDs. So these are things like GP attendance, emergency department attendance, inpatient admittances, and also duration of hospital stays. And I suppose when we think about how much of NCDs we potentially can change versus maybe the conditions that we have no power to change, when you think of how resources are allocated, I suppose it's really important in terms of thinking, if I can, if I can improve how resources are used, maybe I can help some of these people more. So thinking then about the impact of chronic conditions beyond just economic. So obviously we know that there's, a big significant impact of these diseases on our economy, but they also have significant impact on the individual and also the psychosocial burden of these conditions. We also know for other things that poverty is very closely linked to chronic conditions, and that vulnerable and socially disadvantaged people are at greater risk of exposure to certain things like tobacco or poor health. They have limited access to health services and they get sicker and die sooner. So the impact of chronic conditions for those people might be more burdensome than they are for other people in the population. We also know for low resource countries or low resource settings, healthcare costs for these chronic conditions can really quickly drain a household resource. And this forces millions of people into poverty annually and stifles development. So you can kind of see how it's this bit of a vicious cycle, that if you're sick or if you're in a lower, if you're disadvantaged to start with, you're at bigger risk of getting these diseases, which then create this cycle of not being able to afford to eat well or to be healthy. Okay. So thinking about NCDs then in an aging population. So we know that susceptibility to non-communicable diseases increases with age. So as we get older, we're more susceptible to these diseases. And we also know that globally, there's a globally increasing aging population. And this is also driving an increase in those NCDs themselves. Traditionally, when there's been more of a focus on treatment rather than prevention in our medical system, it means that while mortality rates might decrease because our treatment is getting better, because we're not focused on prevention, or we're not necessarily focused on prolonging and improving life, often it means that people are living longer with lots of different NCDs simultaneously. So our mortality rates might be decreasing as a result of better treatment overall. Often people aren't living very well for longer periods of time. So when we look at this then, and this is data, so this is quite old at this stage, it's from 2012, but we can see that age is one of the most important risk factors associated with deaths due to NCDs. And this data would show that there's a substantial projected rise in NCD deaths due to aging, and basically painting this picture of a rapidly rising burden of non-communicable diseases. So we can see here in the blue figures show the increase in deaths that are due to the aging population, whereas the orange bar shows the increase in deaths due to population growth. So you can see that even though the population of the world is getting, bigger, that's not really having as much of an impact on increased deaths compared to the actual aging population. So I guess when we think about non-communicable diseases in the elderly and the older populations, that's why it becomes even more important to address this. So thinking then about what can be done to change this, I suppose, there's lots of different ways that we can think about this. So for example, we can think about what can the individual themselves do? What can I as a physiotherapist do? And what can broader society do? So there's lots of people and actors in the system, and there's lots of potential ways of influencing things. But important just to think about the different people and what different types of people have a role in it changing with. Okay, so thinking about then our individual risk factors. So we know that there are certain risk factors, so things like tobacco use, physical inactivity, unhealthy diet, and harmful use of alcohol. And these are things that really contribute to mortality with non-communicable diseases. But we also know that they're potentially modifiable. So we potentially can change these things. These are things that if we can figure out a way of improving, we could have a big impact on the numbers of deaths and risk factors. So for tobacco, we know that tobacco contributes to over 7.2 million deaths every year, which is set to increase. We know that 4.1 million annual deaths are attributed to excess salt or sodium intake. More than half of the 3.3 million annual deaths in people with chronic conditions are attributable to alcohol use. And then 1.6 million deaths annually are attributed to insufficient physical activity. So we start to see this picture of, these are things that we can potentially change. So how might we go about this? So as well as these individual behavioral risk factors, there's also other metabolic risk factors that are things, related to the individual themselves. So the person with NCDs, what are their risk factors? So we know that raised blood pressure is a key metabolic factor that increases the risk of non-communicable diseases. Also overweight and obesity, high blood glucose levels, and high levels of fat in the blood. We also know that the leading metabolic risk factor globally is elevated blood pressure, and 19% of global deaths are attributed to this, which is followed then by overweight and obesity and raised blood glucose. So this ties in a lot to the Sustainable Development Goals, which you may or may not have come across before now. And these would be, I suppose, just thinking about the health of the world in general and what types of things can we do and what types of goals do we need to have. So this ties into the goal 3.4, which it says that by 2030, we will reduce by 1/3 premature mortality from NCDs through prevention and treatment and promoting mental health and well-being. So you can see here the different targets of it are around cancer, cardiovascular disease and diabetes, reducing physical inactivity, improving diets, and reducing harmful use of alcohol and tobacco. And again, thinking about where the physio comes in around the physical inactivity piece is a place where we can have an impact. So then thinking about the role of individual behaviours in chronic conditions, so we've kind of just touched on some of those, So those 4 major lifestyle related factors that influence the development of chronic conditions. And we know that if we try and improve these health related behaviours, we can have a big impact on chronic conditions and reduce the leading causes of morbidity and mortality. Okay, so when we think about this and where this comes into it, so these are behaviours happening at the individual level, and we know that behaviours and changing behaviours in people isn't always easy, but it's often a recommended part of their care. So looking at some of the guidelines that are out there for older people, so this is a guideline from the National Institute for Health and Care Excellence for older people with social care needs and multiple long-term conditions. So this would say that self-management is a key part of long-term condition guidelines, and that for caring for people, for older people, a key part of their care should include self-care, taking medications, learning, volunteering. Oops, sorry, I clicked ahead there. I'll come back a second. Socializing with friends and hobbies and interests. And so again, thinking about, okay, so this is what's recommended, a recommended part of care for older people, and thinking about where can I, as a physio, play a role in this, and what can I do to try and meet these recommendations. So that'll come into later on when we're talking about community-based approaches, group-based approaches, and where that comes into this. So self-management then for non-communicable diseases has been variably defined in the past, but typically it's the process where individuals with chronic conditions take control of their own health and actively manage their chronic conditions. So chronic conditions, as we were talking about earlier, can result in considerable difficulties for people physically, psychologically, and socially. So thinking about self-management, it's a process where people can try and develop knowledge and skills in how to manage the consequences of their chronic conditions in their everyday lives. So these would be things like trying to manage those behaviours we talked about earlier, and in terms of taking control of their health and actively managing. So when we think about what do we mean by helping them take control? How can we help someone take control of their health? Or how can we help them to actively manage their own condition? What types of knowledge and skills are we talking about? So this is where things like, as a physio, working with your patient around things like decision-making or goal setting, action planning, to help them either manage their medication or to adhere to a rehabilitation program or to engage in physical activity. And all those kind of core skills can be a really important part of your treatment with them. So coming from the individual themselves and what we can do to work with individuals, I suppose it's always really important to remember that for people with chronic conditions and non-communicable diseases, it's typically not just individual behaviours that will determine their health or the impact of those chronic conditions on their well-being. So we know that there's lots of different broader determinants of an individual's health. So this is the social model of health from Dahlgren and Whitehead from back in the 90s. And this, I suppose, is just to illustrate how complicated managing chronic conditions is and how complex it is, because we know that as well as genetic and individual factors that we can't change, things like age, sex, constitution, there's also lifestyle factors like what we talked about smoking, activity, but then there's also things like their social and community networks, and broader things again like education, work, living and working conditions, unemployment, water, health, housing, all these things that also will influence both how they develop chronic conditions in the first place, how our management as a physio will work or will not work, and also their general health and whether they'll be able to participate in things. So I think it's always just really important to remember that, yes, the individual can change things or try to change things. And yes, we as physios can help them or try and work with them to do this. But there's also broader things that maybe we don't have a role in, or maybe we do, but it's harder, and that will also influence how things happen. So I think it's always really important to remember that. So this is just breaking up that model into 4 layers. So the center, the unchangeable characteristics, first layer, things like smoking, physical activity levels. Second layer, quality of relationships and networks. Third layer, access and opportunity to avail of services and amenities. And then the fourth layer, so things like national or international government policy, income, those broader things. Okay. So I suppose where I think it's quite interesting is that often when we think about putting things in place to try and help people manage non-communicable diseases or improve their health, often people say we don't have enough money, we don't have enough resources, we don't have capacity. What's really interesting is that the WHO has done a lot of work in this in terms of figuring out what are the key things that even the poorest countries could do to improve the health of their population. And this is a really nice report from the WHO, which shows that the world's poorest countries could gain $350 billion by 2030 by scaling up known investments in preventing and treating chronic diseases, and also save over 8 million lives. So basically what this means is they have looked at the things that are maybe the easiest to do with maybe the least cost, or the things that would have the best bang for your buck. So the best chance of creating difference, but with not a massive amount of resources needed. So these are what they're calling their best buy interventions. And if you look across the different areas, so thinking about where physio could potentially play a role in this, also thinking about where the individual could play a role in this, and also society. So thinking about these are the cost-effective, feasible options for countries to try and implement, which shows the best evidence for generating impact and value. Okay, so I wanted to kind of just highlight the chronic disease international guidelines that the WHO wrote back in 2002. So these recommendations or guidelines are about 20 years old. But they set out 8 essential elements for taking action in terms of improving care for people with NCDs. So one of those is supporting a paradigm shift. So this essentially means that we're trying to looking at moving the shift of healthcare away from just acute episodic models of care to thinking about how do we make this work better for people with chronic conditions, where it's not just a one-off treatment that they need, but they need a more better healthcare or treatment over the course of a longer period of time. Then thinking about the political environment, so what's the role of policymakers and service planning, and how those core values need to be shaped to ensure that this can happen. Integrated care health, or building in integrated healthcare. So thinking about how do we all work together and avoid that different services are working differently, but how do we bring healthcare services together to work on managing chronic conditions together. So if you think about, if you've ever worked with somebody who has a chronic condition, how often have you maybe experienced, say someone with diabetes, how much contact or collaboration would you have with their diabetic consultant or with their diabetic nurse? So thinking about how we bring teams together to work more effectively. Aligning sectoral policies for health. So things like thinking about the role of environmental policies on healthcare or education policies. So is there policies in education that makes it easier for students and for children to be more active during the day, and thinking about that and how they overlap with each other. Using healthcare personnel more effectively. So thinking about where healthcare providers could be best utilised and where strengths are and how to play to those strengths. Centering care on the patient and family. So again, bringing it back to the patient-based approach and what the patient's needs are. Supporting patients in their communities. So again, moving care away from hospital settings, but moving health services out towards the communities to try and manage people to live better in their communities. And then finally, this key focus on prevention. So trying to kind of look at how do we stop or try and prevent these conditions from happening in the first place. So as I said, this was published in 2002 with this focus on detection, screening, treatment and prevention, and this long-term care that's proactive, patient-centered, community-based and sustainable. So this I suppose idea takes the shift from a traditional biomedical model, or aims to shift things from a very traditional biomedical model to more of a biopsychosocial approach. So I'm not sure if maybe you have come across this lots before, and I apologize if I'm repeating things for you, but thinking about the traditional biomedical model would be focusing very much on the physical processes. So things like the physiology of the disease, pathology, biochemistry, so not really taking into account the role of social factors or individual subjectivity. Whereas the biopsychosocial approach would look at the interactions between those biological factors and also the interaction with psychological and social factors. So that these factors together will determine the cause, manifestation, and outcome of wellness and disease. So essentially, the International Chronic Disease Guidelines would have been saying, okay, we need to move from this traditional biomedical model to more of this biopsychosocial model, where we look at the broader determinants of health and try and address those. But I suppose, how are we doing on achieving these? So this is 20 years ago, and maybe just have a think yourself in where you work currently or where you're about to work. What is the situation in terms of those 8 elements? Is that what service looks like in your country? Is that what it looks like? Or are we still not achieving those 8 elements 20 years on? So from some of the data we do have, we can see that only 48% of countries have evidence-based guidelines, protocols or standards for managing chronic NCDs through a primary care or community-based approach. And that where they do exist, the guidelines are for diabetes, followed by cardiovascular disease, cancer, and chronic respiratory diseases. So only not quite half of the countries involved had reported having these guidelines available. So my sense is that we still have a good bit of way to go with trying to embed all those 8 principles into healthcare. Okay, so this is just a quick recap for yourself. So I'm just going to give you just maybe 20 or 30 seconds just to have a quick read through these and just to try and jog your memory in terms of things we've just talked about. So NCDs have a significant blank, blank, and blank on individuals and society. So what are the 3 words blanked out there? Chronic disease international guidelines aim to shift the focus of healthcare from a blank model to a blank model. What's the missing word there? The social model of health proposes blank layers of determinants surrounding unchangeable variables. And these 4 layers are blank, 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 and blank. So just for your own time. Okay, so I think you probably will have these slides afterwards. You can go back to all of this again, I think. So, okay, so just, yeah, so that's, I suppose, just a very, very broad, very wide thinking about chronic conditions, NCDs, and older people. And I think just that information, I think, is always really helpful to have in the back of your mind when you're working with anybody. With the question there, or no? Okay, sorry. So yeah, so I suppose just always really important to have that bigger picture lens in mind when you're working with these and when you're thinking about what can be done and why is it working, why is it not working, and what can we work towards. So the next section then we're going to move to is looking at the importance of physical activity then for older people with non-communicable diseases. So I never thought I'd be citing Hippocrates in any of my lectures or sessions, but there's a first for everything, I suppose. So back in maybe 460 to 370 BC, I don't know how accurate those stats are, but Hippocrates is supposed to have said, all parts of the body which have a function, if used in moderation and exercised in labours in which each is accustomed, become thereby healthy, well-developed, and age more slowly. But if unused and left idle, they become liable to disease, defective in growth, and age quickly. So I think this is, I just was struck by how prescient this thinking was for so long ago that, and a lot of the time it's not rocket science. If you don't move, you won't be able to move in in a few years' time, or when you're 80 or 90, if you don't move constantly. But it's surprising how that message is still not necessarily getting through to everybody. So thinking about maybe the older people in your lives, or even younger people in your lives, I know in my life, that message is still, say, thinking about older parents and relatives, it doesn't still translate sometimes. I can't understand how they don't understand that if you don't get up and move more regularly, you'll be too stiff and you won't be able to move. But it's still not translating. So just thinking about these, maybe as physios, we think this stuff is really obvious and very simple, but there's something missing in that. Often it's still not getting across to our patients. And maybe that's thinking about all those other different factors we've just thought about or talked about, that maybe those are the key bits. So anyway, so thinking then about the benefits of physical activity for older adults with non-communicable diseases. So we know that regular and adequate levels of physical activity improve muscular and respiratory or cardiovascular fitness. It improves bone and functional health. It reduces the risk of hypertension, coronary heart disease, stroke, diabetes, various types of cancer and depression. So reduces people's risk of getting either more NCDs or NCDs in the first place. And particularly for older people, so these previous three are very, these are common to all age groups or common to many age groups. But for older people where falls and falls prevention becomes a very important factor of our care, being physically active also reduces their risk of falling and having hip or vertebral fractures. And of course, it's also fundamental for energy balance and weight control. So this, so being physically active can reduce the impact of NCDs and also the impact and potential development of other comorbidities or other NCDs. And sometimes it can also contribute to eliminating non-communicable diseases. So physical activity alongside diet, there's really exciting kind of evidence that shows that maybe it might also be helpful to try and reverse type 2 diabetes, which is really exciting. So thinking about that as well, that the massive benefits that physical activity can have for older people. So with this in mind, so we have good quality, well-developed guidelines for physical activity and sedentary behaviour. So the WHO has recently published their 2020 guidelines. So if you hadn't had a chance to look at these yet, I'd encourage you to do so. And they have this for, the guidelines for all different populations and ages. But we can see that they have specific guidance for older adults. So the guidance for older adults is quite similar to people aged 18 to 64 with chronic conditions. But they also, I suppose, highlight the fact that it's so important for preventing declines in bone health and functional ability to prevent falls and falls-related injuries. So as part of the recommendations, they also say that as part of their weekly physical activity, older adults should do varied, multi-component physical activity that emphasizes functional balance and strength training at moderate or greater intensity on 3 or more days a week to enhance functional capacity and to prevent falls. And the recommendations for sedentary behavior are the same as for adults aged 18 to 64. So as well as this, we have guidelines for people with non-communicable diseases. So guidelines for people with rheumatoid arthritis in terms of what types of physical activity they should be trying to achieve and how much, how often, what types of exercises they could do. We also have this for people with heart disease. So for people with coronary heart disease, artery disease, what type of intensity should they be aiming to work at? And what types of things do we need to consider, particularly for working with people with this disease? And also for people, for cancer survivors, they also have recommendations out there. So I guess the thing is, so we have recommendations. So we know that exercise is really good for people. We know that it's really good for and important for older adults, particularly those with non-communicable diseases. We have recommendations, really good recommendations saying how much they should be doing. But we also can see that they're not achieving that. So again, this is data from Ireland, and apologies. I did look for Ukrainian guidance, but I couldn't find it. So, and I don't speak the language, so apologies. So I'm just using the Irish data as an example for this. So if we look at older adults, so aged over 18 years, we can see that only 33% of adults in Ireland are achieving sufficient physical activity levels. And when we look at, so this is kind of European data, so from different European countries, for people aged over 50, spending at least 3 hours per week on physical activity outside of work, these are the different age categories. We can see that there's quite a variation between the different European countries in this. So in Estonia, there's about almost 90% of people aged between 50 and 74 who are spending at least 3 hours a week on physical activity outside of work, compared to down here with Croatia, where it's only about 12%. So big difference geographically. And we can also see that physical activity in the over 75s is typically lower than the younger age group. I think the only place that seems to be different is, for some reason, Germany. So I don't know what they're doing in Germany, but maybe we need to ask them. Okay, so this is more data, just looking at people, again, this is not specific to the over 65s, but looking at the people older than 15 reporting physical inactivity and sedentary behaviour in Europe. We can see that, again, wide variability and geographic differences, and overall quite low levels of physical activity. So about 50% of people from these 30 or 28 different countries report no engagement in health enhancing physical activity. About 46% report never doing exercise or playing sports, and 35% report never engaging in other physical activity. And of course, as I say, this is variable across the different countries in this survey. Okay, so thinking then, so that data we've just looked at is kind of more on a general population level. So that's thinking about what's recommended for older adults, how are they doing, how are the general populations doing. So thinking then specifically for older adults with non-communicable diseases, we can see that they often have even lower levels of physical activity than their age-matched peers, or say older adults with no non-communicable disease. So stroke survivors achieve fewer than 3,000 steps per day and do not meet daily recommended step counts. And then there's an inverse association between physical activity and chronic low back pain. So we can kind of see, and this is just a snapshot of some data from some NCDs, but in general, there is a lot of data that's saying that people with non-communicable diseases are less physically active than people without NCDs. Okay. So moving then just to look at physical activity for older people with non-communicable diseases. So I'm just going to see if there's any questions at the moment. So I'm not sure, Aya, if are we doing questions now or at the end? Just wanted to pause just to give people a chance to take in.
Yeah, right now I don't see any questions, but yeah, please, if you have any questions while you're listening to Elaine, feel free to type them in chat. So I keeping an eye on a chat room. But otherwise, yeah, we should probably plan some time for questions at the end of presentation.
Perfect. I think I have time kind of built in for presentation questions, so that's good. So I just wanted to pause for a second. And I mightn't see the chat, so just if I don't, maybe just let me know. Yeah.
Okay. Thanks. Yes, let you know.
Okay, so then what we're going to come to now is just looking at physical activity for older people with NCDs and thinking about community and group-based approaches specifically. And we're going to look at some examples of this as well. So thinking about why group-based or community approaches. So why am I thinking, why am I even focusing on this piece of it? Why is this important to think about? So this is coming back to what we would have spoken earlier about looking at that bigger picture outlook. So thinking beyond the specific disease condition, but targeting broader health determinants. So things like, what does a group-based or community-based approach, could that help target this second layer here? Could that help facilitate and increase participation in the community? And then also broader than that, if we have better, healthcare services that target or that enable community-based approach, what might that look like as well? So I think it's coming back to thinking beyond just the individual, but broader than that. And what can society, what can community approaches achieve or target that maybe just individual-based programs might not. So also thinking about drawing on social influences or social support, thinking about, remembering back that non-communicable diseases have a significant psychosocial impact and burden on people. And can we target this by those social support networks as well? Is that an important part of our treatment? And how would group-based approach help develop that social piece of it as well? And this being important potentially for long-term adherence to physical activity. So for people with these conditions, we're thinking about how do we get them active, but then also how do we keep them active over a long period of time when maybe they're not coming into physiotherapy sessions anymore, but we want them to be able to, again, pull back in that self-management, take ownership of their condition and manage it for the long term. Okay, so then looking at some different community-based approaches to increasing physical activity in the general public. So I suppose this is one of the reasons why I like this type of work, because it can be really creative and it can be really fun, and there's lots of opportunities to think about different ways of doing things. So for example, some community-based approaches to increasing physical activity for the general public, not necessarily older adults, not necessarily people with non-communicable diseases, but targeting the general public, of which older people with NCDs will be a part of. But there's things like community-wide campaigns. So this is one here in Ireland. It's called Get Ireland Active. And it's basically, you'd hear things on the radio about, have you gotten up for your walk today? Now is a good time to get out for your 20-minute walk, or, so hearing that repeated message over radio or TV, can be an important part of it. So that's one potential example. Other things are pointed decision prompts. So for example, signs encouraging physical activity at points of sedentary behavior. So if you get time after the session, maybe I'd encourage you just to click on this link here. It's a really interesting and really nice example of how they developed a community-based approach to getting people more active. So this is in Stockholm, in Odenplan, where before they put in these stairs, so they had regular steps like you would in any subway system and an escalator beside it. And they saw that people nearly always will take the escalator. People will stand on the escalator and take it up. It's quicker and easier. But then what they did was they put in these piano stairs. So the stairs actually play music according to the scale, the scales of a piano, so that when you step on it, it makes music. And as you can see from this picture, just a snapshot, but they saw that more people started using the stairs because it was more fun and more, interesting to do it than just standing on an escalator. So that's, I think, a nice example of different things that could be done and different things that we can think about when we're thinking about how to encourage and promote physical activity and what types of things are possible. So other examples are creating or enhancing access to physical activity and creating better places to be active, combined with information outreach. So I don't know in your city where you live what you have, but in Dublin and in Galway and different parts of Ireland, we have these city bikes, which is where, bikes at different public access points, you type in your code and then you cycle away. So improving access to physical activity is often a big part of this as well. So again, thinking back to our big socio-ecological model, if the access isn't possible, then it's really hard for people to take part. So think about that piece as well. And then street scale, so community scale, urban design, land use policies. So where you live, are there enough streets or are there enough paths for people to get out and be active? So if you're prescribing exercise for your patient, do they have a place where they can do that? If you're saying, I'd like you to go for a walk twice a day or once a day for 20 minutes, is it safe for them to walk, or is it are there loads of potholes around the roads there? Then active transport to work policies or transportation and travel policies. Again, different types of ways and different types of community-based approaches to increasing physical activity, but things that can also potentially work. Then we have things like individually adapted health behaviour change programs. So like where strategies are tailored to individuals' interests and preferences and readiness for change, and social support interventions in community settings. So this is kind of about developing and maintaining those social networks that can support physical activity. So this is the Football Fans in Training programme. So it's a Scottish-based programme where they targeted it at older men with overweight and obesity. And in order to get them active, they set up the physical activity programme that they would happen in the person's local soccer club. So for these men, Celtic football in Scotland was their main, local team that they followed. And by participating in this, they felt part of the team, and that helped them continue to be active. And this social element that they got from being kind of part of the exercise team helped sustain the physical activity with it. So I'd have a look at that research program, and it's a physical activity program running in the community. I'd have a look at that as well. It's quite interesting to see what they've done. So thinking about, I suppose, the impact then that this can have, so we can see that actually these things can make a difference. So this is just a quick kind of infographic from some US data, but that showed that after the installation of a new bike lane in New Orleans, the number of cyclists increased by 225%. And then by putting together a walking school bus program, 125%, or the number of children walking or biking to school increased by 125%. And then the recreational facilities put into outdoor parks, people who use those equipment started to exercise 46% more frequently than those who didn't. So thinking just about improving access to physical activity and things that can be done in the community on a very broad level to try and promote physical activity. Okay. So we've talked a bit about, we've just talked about now about maybe kind of very general programs for the general population, things that can be done on a very broad community level to increase physical activity. So I think then bringing it back to the individual person with an older adult with non-communicable disease, thinking about how community-based approaches might be important or might be helpful for them, I think is good to look at it in the light of this international classification of function and disability, or functioning, disability and health. So this is the ICF framework, and I'm sure you've probably come across this before, but this would essentially state that functioning and disability are multidimensional concepts relating to the bodies, functions and structures of people. So for example, their, the bone health, their muscles, their strength, that type of thing. And that these, and the impairments at that level, so what's their function at the body level, and that this also relates to then their activities. So, and the function at the level of the individual in terms of what can they, what types of activities are they able to do. So thinking physiologically here on the left with body functions and structures, the activity then in terms of what they can actually do with that, and then our participation on the right. So this also influences how they're able to participate in all areas of life. So functioning as a member of society, and that these, I suppose, these concepts are really influenced by both personal factors. So thinking back to the individual's perceptions, beliefs, that type of thing, but also environmental factors as well. So this kind of integrates that biopsychosocial model that we talked about earlier with this kind of with this social ecological model of health, but bring it back to maybe a person with a health condition and all the different levels that we can think about. So this participation piece is particularly maybe important in terms of thinking about our community-based approaches or our group-based approaches in terms of what we might be targeting. So yes, we're targeting the body functions and structures. We're targeting their muscle strength and their bone density, but we're also targeting their ability to take part in society and to participate in things. Okay. So I just wanted to, I'm hoping that my sound plays. I must share computer sound. Okay, I think I have a thing to do that. So I wanted to just show you some examples of different community-based group exercise programs for older adults with NCDs that have been done. So this is research done by colleagues of mine in the University of Limerick, where they looked at dancing for Parkinson's disease. So this is a feasibility randomized trial. So they're currently looking at, you know, beyond the feasibility, I think they have funding to look at the effectiveness of it now. But this essentially was looking at Irish set dancing classes versus usual care. So people with mild to moderately severe Parkinson's disease were randomized to go to Irish set dancing classes or usual care. And what they found was that this set dancing is feasible for them, it's enjoyable, and that it might improve their quality of life. And as I say, they're going to continue to evaluate in terms of what's its effect on physical activity, on the disease characteristics also. So what I found interesting about this is it's also been shown to be sustainable within community initiatives. So Move for Parkinson's is an Irish based charity, and they essentially help people with Parkinson's. And one of the activities that they now offer as part of their offering is set dancing classes. So we can see that, okay, so this is potentially effective for people, but it's also something that could be run in a community-based approach, which I think is really important when we're developing things, that they need to be able to be feasible long-term and not have a massive amount of resources needed for them. Okay, so just back a second. I was going to show you, okay, I think it might be coming up in shortly. Okay. So then another one I'm going to talk to you about is community-based group exercise for older adults with cardiovascular disease. So this is run by a program or by a charity again called CRE in Ireland. So CRE is the Irish word for heart, and they're a cardiovascular disease and stroke charity. So they came up with this My Action program, which is what it's called. So it's a 6-week community-based cardiovascular prevention program where they would have health promotion seminars, group exercise, individual consultations delivered by a multidisciplinary team. So physio is a very integral part of that. So it would consist of 1 hour of group education. Okay, so it consists of 1 hour of education and health promotion and an individual 30-minute meeting to review health goals. So it was based on the trans-theoretical model of behavior change, which I'll talk through in a little bit. But this model would say that individuals, different people are at different stages of change. So what they did with this program then was they targeted the behavior change component to different people's level of change. So for example, they used motivational interviewing and goal setting techniques with patients, but targeted these depending on where the person was at in relation to their stage of change. So this then, so this is what they found. So the evaluation of that program has been published recently. And what's really lovely is that they found that the proportion of people, so this evaluation was specifically focusing on people with type 2 diabetes. And what they found was the proportion of people achieving the target HbA1c levels increased significantly from 53% at baseline to 75% later on. That systolic and diastolic blood pressures were significantly reduced, and much more so significantly higher people met the recommended targets in diet and physical activity, and also that the psychosocial measures significantly improved. And I think really importantly is that the majority of these improvements were sustained at 1 year post intervention. So I hope this will play. I think I might have to share computer sound. So I think hopefully you will be able to hear this. So this is just a very quick video of that CREAM iAction program and some of the work that they would have been doing in it. So hopefully this plays for you. Okay, so I'm just going to step back a few slides because I had a slide. I want to show you the set dancing classes, and I think it skipped a little bit. So the classes I was talking about for the set dancing, and again, hopefully you can hear the sound of this. But this is what Irish set dancing looks like. So I wanted to show you this slide a few slides ago. I don't know why it didn't come up, but I'm showing it to you now anyway. So regular physical activity is a key recommendation for people with Parkinson's disease, but approximately 64% of them have sedentary lifestyles. So Irish set dancing is this, it's a type of dance, kind of cultural heritage type of dance, where there's a very predictable rhythmic beat, and people, I suppose that the type of dancing that it is lends itself quite nicely to helping people develop complex motor skills, dynamic balance practice, musical cueing, and through the musical cueing, and also that social participation piece of it. And the lovely piece of it as well is that they involve the person's partner. So I'll just play this just to show what that set dancing that I was talking about looks like. Hopefully you can.
Very much. Lead around, turn around. 5, 6, 7, step. Turn around. Swing. Hey. Ladies in. Change. Right hand guys. And change. Top ladies cross. Cross again. Square the house. Woo. Set back. And home. And from square. John O'Neill.
Okay, so I'm going to pause it there, and apologies that didn't play in the place it was supposed to play. But I suppose for anyone who's worked with people with Parkinson's disease, you can see the people with Parkinson's disease in that clip. And I suppose just thinking about what this type of exercise might be doing for them, both on a physiological level, but also the participation piece of it and the engagement that they might not get from an individual physiotherapy program. Okay. So I'm going to move on back to, so we've just looked at the CRE program for people with cardiovascular disease. So the next one then I just wanted to look at with you was the community-based group exercise program for older adults with multiple sclerosis. So this is the Step It Up program, again led by colleagues in the University of Limerick, where they took 65 ambulatory people with MS and randomized them to either 10 weeks of group-based exercise and social cognitive theory-based education versus exercise and an attention control education. So the education without that behavioral theory piece. Okay, so what they did was they found that there was increased physical activity in the group and improvements in fatigue, strength, goal setting and planning for both groups. They also found that there was preliminary evidence for improvements in the physical impact of MS, anxiety and depression and cognition in the exercise and social cognitive theory group alone. So what that tells us, I suppose, a little bit is that it's important to think about what is the behavior theory, what's behaviorally going on, so psychologically, what's that piece of it? And for some of you who would have attended my previous UFAPA rehab lecture, I talked a good bit about that, so I won't go into it in massive depth today, but just thinking about that piece of it. Okay, so the other program then, just another snapshot of different types of programs that can be done. This is for adults with, for older adults with chronic pain. So this is a program I worked on myself. So it was led by Dr. Deirdre Hurley from University College Dublin, and it's the SOLACE feasibility randomized trial where and SOLACE stands for self-management of osteoarthritis and low back pain through activity and skills. So this was a complex behavior change intervention looking to promote physical activity through and self-management for people with osteoarthritis and low back pain in primary care physio setting in Ireland. So it was 6 weekly group-based education and exercise sessions. And what we found was that we were looking at feasibility of this program, we found that the intervention was acceptable for both physios and for patients, and preliminary evidence of small effects on secondary outcomes on pain, disability, function, and behavior change. The issue with this program was that it was very difficult and too difficult to get enough people for a full RCT. So that was one of the main challenges with demonstrating how effective this program was or not. However, there have been similar programs that have identified, very similar programs that have shown evidence of effectiveness. So for example, the Escape Pain program by Mike Hurley in the UK is a very similar program, and they have demonstrated really good evidence of effectiveness for that program. Okay, so I guess the key then, to kind of summarize some of the key points here around these different types of community or group-based approaches to increasing physical activity for people with NCDs and for older adults. Essentially, it's this ethos about getting people moving. So getting older people up and going, but also then considering their condition, their abilities and their needs. Thinking that our outcomes of interest is often physical activity plus other disease-specific health outcomes. So maybe things like blood pressure, fatigue, strength, those types of things. Thinking about focusing on long-term sustainable behavior change. So how do we get them to embed physical activity into their lives on a sustainable level? And then this piece about the social dynamics and group dynamics and social participation, that tapping into that piece of it within these programs to try and help them to be more active. And then this sense of getting them to live well with their condition. So for people with chronic NCDs, typically the conditions aren't going away. So it's about trying to help them self-manage over the long term. And moving away from hospital-based clinical settings towards these community-based settings and approaches. So just the last, I suppose, little bit that I'm going to talk through is just the group bit. So what's so important about the group bit of it? So this is this piece of literature is, I suppose, a key reading. So I've highlighted this at the references for you to take a look at when you get time. It's just a really nice systematic review that looks at the group piece. So we have evidence that the group component can help promote adherence to physical activity recommendations in older people. And I suppose thinking about that, why might that be? So this review by Claire Farrance et al. Showed that there's some indication that community-based group exercise programs have long-term adherence rates of almost 70%. So this is quite good in terms of thinking they're getting these people to be active for over a long period of time of almost 70%. What they found was that with these types of group-based programs, the key themes and the key things that are important in order to help people to adhere, and the key bits that are, the group bit are bringing to it, are this idea of social connectedness, so that they feel they belong to something and that they're part of something. That is a key bit of helping them continue and helping them adhere to the physical activity. Perceived benefits, so that they're feeling, improvements in their condition or improvements in their physical or mental health or well-being from it. Also program design, so things like the convenience of the location of the program, or where it's held, how easy it is or affordable it is to take part in it. Then things like empowering or energizing effects. So how engaging is the program? How energizing is it? And then instructor and individual behavior. So the person who leads the program, if they are, I suppose, quite engaging and enthusiastic and motivating, that helps people, to stay going and to adhere to physical activity over the long term. And also individual factors as well. So experience with previous physical activity programs and group-based programs too. Okay. So thinking about this then, important also, I think, to remember that physical activity is a behavior. So thinking back to, our learnings from previous sessions, what is a behavior? So behavior is anything that a person does in response to internal or external events. They're physical events that occur in the body and are controlled by the brain. So engaging in physical activity is a health behavior. And health behaviors specifically are activities undertaken for the purpose of preventing disease or for improving health and well-being. So when we're thinking about group-based physical activity programs, important to remember that these are about changing behaviors and trying to get people to change their physical activity behaviors. So when we talk about these programs, it's good to have a sense of behavior change theory and what we mean by this. So I'm not going to go into detail in them today because there's lots of different types of theories, but these are some of the most commonly applied behavioral theories in physical activity research. So things like the theory of planned behavior, the self-determination theory, the COM-B that we looked at in previous lecture, and social cognitive theory. So these are just different types of ways of hypothesizing why might somebody engage in physical activity or not. But what I think is interesting in all of these is that all of these, or many of these behavioral models or theories, highlight the role of social norms and social participation and that type of interpersonal relationships as an important component in changing somebody's physical activity behavior. So the theory of planned behavior, this idea of the subjective norm. So how normal is exercising or physical activity? For self-determination theory, relatedness. So this interpersonal connection piece. In social cognitive theory, again, social norms, community involvement, influence on others. And then in the COM-B, this social opportunity piece of it. So again, thinking about why is the group-based bit important? Why is that helping? Why is that a factor in this, in changing physical activity behaviors? I think it's helpful to look back to some of these behavioral theories to think about that and explain some of it potentially. So just taking one of those very briefly to look at. So this is the COM-B model. And again, I won't spend much time on this today because I have looked at this before. And, this is just a very quick introduction to this again. But the COM-B model would state that in order for a behavior to occur, it involves identifying what needs to change in terms of capability, opportunity, and motivation. So in capability, are they able to engage in the behavior? So for physical activity, do they have the physical capability and the sufficient lower limb strength to squat or to walk? Psychological capability, do they know the risks associated with not being physically active? Do they know about the benefits of being physically active? Motivation, so things like automatic motivation. So what are their habits around exercise? What are their emotions or their fears? And then reflective, have they thought through or set goals around taking part in exercise or physical activity? And then this piece that we're supposed particularly talking about with the social element and the group-based element is, what is the social opportunity? So in terms of social norms, are they able to exercise? Is there judgment from their peers in terms of being able to exercise? And then physical opportunity, can they run on the roads? Is there a footpath there? Can they afford to do this? So this is just looking a quick snapshot at one of these behavioral theories in terms of the different things that enable somebody to take part in a behavior change like physical activity, and what are the types of things that might be playing into that. And one of those is this social opportunity piece. Okay, so then just as a very kind of final piece of this, and just to kind of think through some of the final thoughts, I suppose, maybe that you might have on this, is just to think through what is the role of the physiotherapist in promoting non-treatment physical activity. So what is our role as a physiotherapist? So I think a lot of the time we're very focused on treating an individual patient, coming up with an exercise program that targets very specific, neuroplasticity changes, or it's very specific for this rehab component and this very specific piece. We're focused on treating maybe the impairment. So they have decreased quads muscle strength, so we're going to focus on increasing that. And I think that's often what we're very focused on. Whereas thinking broadly beyond that to general physical activity, how often and what do we think about getting our patients or people to be physically active in general, not just very specific treatment focused? So this is some research that's been done on non-treatment physical activity and what physios believe about this. So this is one, it's a PhD work done in Australia, where they looked at how do physiotherapists feel about promoting physical activity, so non-treatment physical activity, and what types of factors influence whether they do this or not. So the things that made them more likely to prescribe general non-treatment, non-specific physical activity were things like knowledge, prioritizing physical activity promotion over other issues. So weighing up what your patient is presenting with and prioritizing, I'm going to focus on this non-treatment physical activity with them. And also feeling that physical activity promotion was compatible with their daily practice as a physio. So other work that's been done has looked at physiotherapists working in medical or surgical care. So this is another study that was done with 22 physios, a focus group to explore what they felt. And they found that health promotion was part of their role, but they were very much hindered to do this general non-treatment physical activity health promotion by things like time constraints, needing to focus on the discharge of their patients, and skepticism about whether this would be effective or not. What's interesting is a lot of these programs have focused primarily on promoting physical activity with patient populations. So with people who come into us for treatment or people who are referred to us. So it doesn't really look at the general population. And I suppose that's one of the things maybe I'll get you just or ask you to think about in your practice and maybe now is just what's our role in promoting physical activity for general populations? So not necessarily for people with a chronic condition or for people who come into us off the street or who come in and make an appointment, but what is our role in general in promoting physical activity? So this has been less explored to date. So there's work done, and this is a good bit old now, this is 10 years old. It was looking at the Irish curriculum in terms of how we educate our physiotherapists. And it found that in our curriculum, when we train physios at undergrad and level, physical activity, exercise promotion and prescription for specific conditions is very well represented, whereas the areas that are absent or lacking are things like physical activity or exercise for public health in general, strategies for changing physical activity behaviours, and physical activity or exercise for lifestyle-related diseases. So just to give you a few moments to think about it yourselves, and I'll maybe just give you 20 to 30 seconds just to think about these statements. So what do you think? So a physiotherapist's role is to look after the patient in front of us. Disease management or secondary prevention maybe, but not primary prevention. Prescribing individual exercise programs for clinical populations is part of the physiotherapy role, but not really general physical activity. And given physiotherapists' expertise in physical activity prescription, physical activity promotion for disease prevention for all populations should be a core part of our role. So I'll just give you just 20 seconds maybe just to think about each of those statements and what do you feel about each of those? Okay, so so the next thing I'm just going to flag with you. So I think this is a really interesting report. I guess it's more of an editorial or an opinion piece, but it was written by Sandra Hartley in 2019. And I think it's a really interesting read as a physio to go through. So I have highlighted this again as another piece of key reading. So, so health promotion then, so basically Sandra Hartley has written this piece about reimagining the role of the physiotherapist when managing people with long-term conditions. And I suppose in a sense, the overall focus of this piece is that health promotion can be influential in changing future healthcare landscape to prevent long-term conditions or non-communicable diseases. And and that we're really well equipped to play a role in the prevention and management of LTCs. And the complexity of comorbidities and a transitioning healthcare system that demands cost-effective services provides many challenges to navigate. And I suppose that's just something that's important to think about, is that while we might think that, yes, this is important and we want to include it in our care, how does your manager feel about that? And how does that compete with when you have a lot of time demands on your, and you're very pressed to get through your waiting list? What is how supported are you to do this and to think about general physical activity and health promotion? Okay, so this is another key reading. So I've maybe highlighted 3 or 4 kind of key references that I think are helpful to read. And this is the Active and Healthy, the Role of the Physiotherapist in Physical Activity briefing paper from the World Congress for Physical Activity. So this paper essentially would so the previous statements that I had put up, some of them were a little bit, our role isn't, managing general health promotion. Some were, that is our role. I guess that the stance that the WCPT would take on it is that we do have a role in advising and assisting the population to use physical activity to keep active and stay healthy. Physio's knowledge and our specific knowledge of function, movement, specific exercise and activation, with knowledge also of the effect of disease and disability on function, is central in exercise prescribing. That we have a comprehensive understanding of the concept of physical activity and use physical activity in different ways, different levels, and in lots of different diverse work areas. And that as members of the MDT, we have a role to work with other health professional colleagues to contribute towards addressing the impact of non-communicable diseases. So I guess this is the sense that would be coming from the WCPT, is that yes, we should be more active and more involved in this. But I guess knowing the demands on our time and our role and what we're expected to do, it might not always be feasible. So just things to, again, think about how can we do this within our current roles. Okay, so just in summary then, just to kind of maybe sum up the whole, the full program of it and what we've talked about today. We know that NCDs are an ever increasing global burden, both economically, individually and socially. We also know that we can prevent this, or we can do a lot to prevent this, but we also need to be aware of the multi-level factors influencing health and well-being, and that it's very challenging to prevent these, even though we technically can do this. We know that physical activity programs are vital both for the general population and also for older adults with non-communicable diseases specifically. And we know that group-based and community approaches to physical activity promotion are particularly important in that they can help sustain adherence to physical activity. They can be sustainable approaches that can continue over time. And this piece of the social participation and the enjoyment factor can be really beneficial from them. And then finally, just to think about, we have a crucial role to play in this, and just to leave you to think about what should this role be. Okay. So I'd like to thank you very much for listening, and hope the sound and everything was okay and that I didn't speak too fast. I have a habit of doing that sometimes. And just, if we have time for chats or questions, I'd be happy to do that.
Thank you, Elaine. So I will start with a question which came after you ask actually for questions. So there's a question about, you were comparing chronic disease 100 years ago, 200 years ago, and now. Have the leaders, or like probably it meant those most prevalent diseases have changed in a history time? Did you understand the question?
I think so, yeah. I think it's a very hard question, I think, to answer. So I suppose thinking back to I'm not sure if I know, say, in terms of 100, 200 years ago to now. I think the data I would have been presenting was mostly in the last maybe 10 to 20 years.